All right, friends, how's it going? My name is Dr. Jim Jobin, and this is going to be as brief as I can make it, talk about the changes that you're going to see in the Diagnostic and Statistical Manual, 5th edition text revision, aka the DSM-5 TR. So today's talk is specifically for clinicians. I'm not doing this for the general public. If you are somebody who really likes mental health and you're interested in this, great. But I'm not going to water it down very much. I'm not going to explain a lot of this stuff. I'm really just going over what I know other clinicians know and then what they actually need to know about the changes. Okay. So we are not getting into a lot of the weeds. I am really just talking about what you need to know and kind of keeping you up to date. So it's going to be a fast and furious breakdown, but let's talk about what we're going to talk about. That's probably a good idea in order to make any actual headway. Must talk about what we're going to talk about. So table of contents, we're going to go over why you should care in the first place. I think that's probably important. There are new disorders that need to be addressed, so I'm going to introduce those to you. There's also new diagnoses. These are different than disorders. These are just coding points, but they're very important to getting everything nice and clean. There's also some new language. You're going to see that a lot of diagnoses that used to be very exclusive to each other are now allowed to live together, and these are called superimposed. So this will change the way you do differential diagnosis. There's going to be some name changes, which are going to be meaningful and sometimes confusing. So I'm going to point those out to you. And then there's going to be some criteria changes. Some of the normal routine kind of disorders that we face have some criteria changes inside of them. That's important so that you can reach a correct diagnosis. And then some of those disorders have specifier and severity changes. We're going to go over that. There's some language changes with some of them that are just clarifying the intention and clarifying what the meaning of the disorder is, which is actually very important in some cases. And then we're going to finish with my quick examination of, hey, should you even buy this? You know, what is the value of this? How should you interact with the DSM-5 TR? So let's get started. But if you're wondering, hey, how do you know all this, Jim? Are you some special guru? No, this stuff's all available. It's available through the publisher, the American Psychiatric Association. Here's the actual link. I'm sure it's not clickable, but if I leave it up here for a second, you can kind of get a feel for where you need to go. Just go to psychiatry.org and kind of navigate into educational resources until you find the new DSM-5 fact sheets, and they break down and they just one by one tell you, here's exactly what we changed in the TR. So that gives you the high points. There's a lot of small changes throughout the TR, but they just let you know, here are the changes. Okay. So let's run through it really quick. Let's start by why you should care. You're not an idiot. You're a professional. I am really frustrated by how many people I'm seeing online, colleagues in various disciplines, but a lot of times in mental health, that are saying things like, oh, nobody cares. You know, I don't use the DSM-5 a ton. I don't bill insurance very much. I'm out of network. So a lot of my stuff is, you know, selected, but not necessarily scrutinized. That's fine. But you should care because you are a qualified professional. You are trusted by the public. You have licenses and you're not an idiot. Only an idiot would say, none of this matters. I don't need to even be aware of what the current cutting edge standards of care and definition are in my field. You're better than that. You're not an idiot, so you should care. Number two, diagnosis is a special power. Not everybody can do it. And when it comes to mental health diagnostics, very few healthcare providers feel comfortable doing it or are scoped to do it. You're among the privileged few that have that special power. You have to be worthy of it. So you should care about these changes and you should make yourself completely aware of them. And last, believe it or not, you're clinically, ethically, and legally obligated to be competent in the application of the current standard, even if you don't use it very much. So this becomes the new standard. There are some changes. You need to be aware of those, and you are obligated legally, clinically, and ethically to apply those standard changes and to know what they are in case you ever have to document things. All right, so let's get into the very first piece, which is the new disorders. So the big headline of the DSM-5 TR is this new one. It's called prolonged grief disorder. Now, if you went back to DSM-5, you would see that this was actually already there. It was referenced in a section about objects of further study. And so they were proposing using this back then. And of course, in the 9 years since the DSM-5 was released, we have had the enormous COVID pandemic and millions and millions and millions of people die. And so more than ever, we have gotten to study grief and the nature of that. So prolonged grief disorder And I'm going to go through the criteria. I'm going to keep it pretty broad because I know you know how to read. And you can always pause this slide and go back. This is the actual criteria as I have seen it published. I do not have a DSM-5 TR yet. That's because they're back ordered. I expect to get one in May, but all their stuff is already out there. So based on the information I've encountered, these are the criteria for prolonged grief disorder. So you have death of a loved one 12 months ago or longer. That's important because bereavement is usually kind of acute. This is definitely bigger than that, right? It's a year, it's chronic. There's that persistent, clinically significant response most days or daily for the past month. So even though it's been 12 months, most days we've been seeing this problem and daily in the past month. So this is how we still kind of consider what clinical distress is. So we're seeing an intense yearning for, let me just get out my little marker thing, I guess. We're seeing an intense yearning for the person, preoccupied thoughts of the person, at least 3 of the following most days since their death, and daily for the past month. So you can see there's a whole list here, but identity disruption, feeling as though part of oneself has died since the death. Let me turn on my little marker pen. That way you can actually see what I'm looking at. How do I do that? I don't know. Whatever. Oh, there it is. Vanishing pen. Okay, cool. I'll use this thing. Sorry. Okay. Identity disruption, marked sense of disbelief about the death. And again, a year afterward, that seems pretty significant. Avoidance of reminders that the person is dead. So in children or adolescents, this may be characterized by efforts to just avoid reminders entirely. Just, almost PTSD response, like just avoidance, right? Intense emotional pain, anger, bitterness, sorrow related to the death, difficulty reintegrating into one's relationships and activities after the death. Examples like problems engaging with friends, pursuing interests, and planning for the future, emotional numbness, absence of marked reduction or emotional experience as a result of the death, feeling that life is meaningless as a result of the death, intense loneliness as a result of the death. And before I continue, just a reminder, we're looking for these most days since the death and daily for the past month. Okay, so all of that's really important. Clinically significant impairment, which you're used to, you see that with all disorders. The duration and severity exceeds cultural norms. This is important because in some cultures, they do have an understanding that grieving will exist for a certain amount of time, and there's sort of an expectation of what that looks like. But we're talking a year or longer, and we're talking, in a sense that it's very acute still. And then, of course, the symptoms are not better explained by another disorder. So that's the big new one, F43.8. The next one that's new is unspecified mood disorder, or F39. And you might be thinking, those of you who've been in the game for a long time, what the heck? I remember that from DSM-4TR. Yes, it used to exist. It was in DSM-4TR, and then it was removed in DSM-5, but it's been brought back in TR because there was a need to fill that gap between depressive disorders and bipolar disorders. If you remember, DSM-4TR had bipolar and mood disorders all in one space, and then DSM-5 separated them into bipolar disorders and then mood disorders. So we needed this one, unspecified mood disorder, to kind of catch space between these two. So it's back. Okay, new diagnosis codes. So these are really big changes that have happened, and I'm really excited about this. I think it really adds a lot to the field. So we now have the ability to actually use a diagnostic code for suicidal behavior specifically, and we have 3 varieties. You can use T1491A for initial encounter of a patient who's having suicidal ideation or an attempt. You can use T1491D every time after that if you're still noticing the behavior. And then, of course, you have Z9151, which is a history of suicidal ideation or suicidal attempt. Why is this important? It's important because previously we could only write as a specifier that people were having suicidal ideation, or we would have to just write it in our assessment, and it was languaged, but it wasn't coded. So by having this as a specific code, this will allow the field to track suicidal behavior very closely, and we'll be able to notice when it shows up in situations that are not necessarily clinical depression, because sometimes somebody does have something else going on. And so it is really important because historically we were kind of stuck to suicidal depression rather than suicidal behavior. So this opens up a little bit more information. Then we also have this one, which is really important, non-suicidal self-injury. And this comes in some varieties too. You have F4588, which is it's current. You're currently seeing non-suicidal self-injury. So again, this is self-harm, cutting. And this is important because historically, many therapists know that whenever you see a patient who is self-harming in some way, it isn't always suicidal in nature. In fact, many times it's a coping mechanism. So it's really helpful that we have some kind of way to language this so we know that it's not just merely a simple thing. It's not always suicidal. So non-suicidal. And then of course we have this one, Z9152, which is a history of non-suicidal self-injury. Moving right along. Next thing on the topic board here, there's a language change in a lot of the diagnostic criteria having to do with this word. Now, this word superimposed existed back in the DSM-4 days. And so we're bringing it back in DSM-5 TR. And so you're going to see it in a variety of places, and I'm going to point those out to you. But functionally, what this is going to do is take a both and approach instead of an either or approach. Instead of saying, hey, they can either have major depressive disorder or bipolar, we're now going to leave room for multiple things to exist at once, or even for psychotic disorders to coexist with mood disorders, because usually we say, oh, it's not better explained by. So let's take a look at this. The first one here, you can see bipolar 1 and 2, okay? So criterion B in bipolar 1 and criterion C in bipolar 2, they've both been changed to allow for the possibility that the person has a diagnosis of bipolar and it coexists with a psychotic disorder like schizophrenia, schizophreniform, delusional, and others. So this is that both and approach. It used to be you can have this disorder unless it's explained by something else. They're now leaving room for the two can be superimposed. Major depressive disorder, they changed criterion D. So that made it, which it had an either or statement about episodes being better explained by other disorders. So it used to say like, oh, if schizoaffective better explains the episode, then don't choose this. But now they allow for the superimposed reality because some episodes may involve other disorders. So somebody may have had multiple episodes of major depression. Some of them did involve other disorders, some of them don't. So they're allowing for the superimposed, and they're also saying, hey, the basic components of major depressive disorder are still accounted for in the diagnosis. So it also converts to a both and standard. Here's another one, other specified depressive disorder. So there's examples in this one. And the fourth example is now adding the superimposed diagnosis. So it goes along with this other understanding that like psychotic disorders can exist, but it's distinct from it. So again, it's that both and standard instead of either or. So in another area of change, we have new names for disorders. So we've actually changed some of these. DSM-5 TR changes some of the wording. So social anxiety disorder is the new standard. The phrase social phobia has been removed, and they state that this is really just because of, you know, what people are comfortable with at this point, what they've been using as the name. And so we're just going to start using this instead. So that just makes it a little bit easier to understand. Persistent depressive disorder, dysthymia has been removed. So if you remember in DSM-5, I believe the title had both of these, and now they're just removing dysthymia completely. Several reasons are given for that. Mostly that dysthymia has misleading characteristics that this isn't, and they want this to be this bigger picture. So dysthymia is kind of moved to the history box, and this is the new actual disorder, and you should memorize that criteria because it is different than old school dysthymia. Olfactory reference disorder, olfactory reference syndrome. If you remember in DSM-5, it's in the OCD disorder chapter, and it has like kind of an area where they point out other areas that people might have OCD symptoms. And in that one, they refer to it as Jikoshu Kyofu. And they felt like this was confusing people because it was giving people the impression that it was only relevant in Japanese society. So they're just removing that and just calling it this. And that just helps people kind of remember that it's an actual characteristic. Intellectual development disorder, intellectual disability. They're changing the language that it's now intellectual development disorder, and they're putting intellectual disability in parentheses. This is the actual name. They're doing that because it's more mainstream. There's less stigma. It better characterizes the nature of the thing. And then lastly, I think functional neurological symptom disorder in conversion disorder. So what they're doing now, they used to be called conversion disorder. I think this was the main title, and then this was in parentheses. They've swapped those, I believe. And so now we have it this way. And the reason why is that functional neurological symptom disorder is the correct nomenclature internationally. So that's more mainstream. And then conversion disorder has some stigma surrounding it and some cultural sensitivity. So they want that to kind of bump away. I wouldn't be surprised if DSM-6 just eliminates conversion disorder altogether. They're leaving it there for now because that's what people are familiar with, and they want people to still have that mental shortcut. All right. Oh, there was more. Okay. And this one, other specified delirium. In other specified delirium, there was a section that was designated as attenuated, or no, I think we're changing it. Yeah. So it used to be called attenuated delirium syndrome. That's being changed to what this is, subsyndromal delirium, because this is a better nomenclature match to international standards, and it actually makes sense. If you're trying to remember what the heck is that, it's diet delirium, basically. It's like delirium light. And so instead of attenuated, which kind of communicates that idea, they thought subsyndromal, which, as you know, means it's below a syndrome, just kind of helps identify this better. So that's another name change. So there's also been some changes to diagnostic criteria, and I'm going to round those up for you real quick. Autism spectrum disorder. It used to just say in criterion A, the following, but they've changed it to all of the following. And that's to just make sure that people are knowing all of criterion A is intended for the diagnosis of autism spectrum disorder. There was definitely some misunderstanding of that, and we've seen a little bit of overdiagnosis of ASD, and so they're clamping down on that by saying, hey, all. So make sure you have all the criteria A pieces in order to get to that diagnosis. Avoidant restrictive food intake disorder. So they eliminated the criteria that said failure to meet nutritional and energy needs because it was redundant. It was actually clashing with this one, interference with psychosocial functioning. So they want us to prioritize psychosocial functioning, not making an assessment of whether or not they're meeting their nutritional energy needs, because this is what we need to focus on. It ultimately becomes a functional comparison. Delirium criteria was revised so that awareness of their environment was made clear and distinct from reduced ability to focus. If you go into the literature on this, it kind of explains like this is what they wanted you to focus on, whereas reduced ability to focus kind of left the radar open to a lot of things. So they want this. So they're putting that on there for delirium. And then depressive disorder due to a medical condition. Criterion A was revised to better match depressive disorder due to a substance and medication to avoid looking for evidence of elevated, expansive, and irritable mood. So they're just matching due to a medical condition with the rest of depressive disorders, or especially this one, depressive disorder due to substance, because they didn't want people going on a scavenger hunt looking for this when that wasn't necessary. Okay, some changes in specifiers and severity. So bipolar 1 and 2, they now have some different language. So mood congruent and incongruent psychotic feature specifier, that was changed so that it's optional during both manic and depressive episodes. It used to just be available during manic episodes. So if you go back into DSM-5, you can see that you can just choose this specifier for manic episodes. During the manic time, is it congruent? Is it incongruent? Well, they said, well, that doesn't make a lot of sense because bipolar is two things. So they also created a category to do that for depressive episodes. And then mild, moderate, and severe specifiers have been updated so that they can also be applied to the manic episode. So remember, this kind of language, mild, moderate, and severe, used to only apply to depressive. And they said, well, that's not super helpful. So like we need to be able to differentiate what is mild, moderate, and severe with a manic episode. And they also have language for that, by the way, before I move on. They do explain how they're going to think about that. It has to do with disruption, and it has to do with how much care the person requires. So severe manic is going to be like the person requires like 24-hour oversight, and then moderate and mild require less oversight. So you'll see that whenever you get into the book. Persistent depressive disorder. In this one, it had 7 specifiers originally. They trimmed all those down to just one, or to only anxious distress and atypical features. And so they felt like that was just a way to simplify their specifiers. So again, persistent depressive disorder, which is not referred to as dysthymia anymore, they've shortened the specifiers list. So there's only the one now. One or two. Clarifying language changes. So intellectual development disorder, which we talked about, intellectual disability, in that chapter, they made some clarification changes. So there was some language cleanups that people don't confuse additional diagnostic features as criteria. There is a section where they just discuss diagnostic features additionally, and some people were misunderstanding that and believing that was part of the criteria. So they've cleaned that up to make sure there's no misunderstanding there. And then here was important too, there was clarification about the IQ score. So in the language, it says, hey, 65 to 75, but now they're changing it to say, look, it's not written in stone, but if they have higher than 75 IQ, you really need to be thinking hard about whether or not IDD is the correct diagnostic. Gender dysphoria. This will probably make some news headlines because it is interesting. They've edited the language to be more gender affirming and to make sure there's not stigma about it. So the edit in the language is desired gender. They changed that to experienced gender. This phrase, cross-sex medical procedure or hormonal treatment, they've changed it to gender-affirming medical procedure or hormone treatment. Again, you can see the language change here. From desired to experience, they're validating what the person's going through. From just a cross-sex procedure to affirming, implying that the patient's not wrong, that this is what the patient desires. They've changed this language, natal male and female, to what was assigned at birth, right? Individual assigned at birth. So again, to validate the human experience, not to just go with biology. And then here, disorders in sex development were changed to differences in sex development, again, to be careful not to over stigmatize what that is. I don't know if I have it in the PowerPoint, so I'll just say it while I'm here. Just a reminder, clinicians, dysphoria is the diagnosis. So it isn't that the disorder is not this person doesn't feel resonant with their assigned gender. That is not a disorder. What the disorder is the specific dysphoria that this human's experiencing as a result of that reality. That's what we treat. We're not doing treatments that are like here to convince them to be one way or the other. That's just not our place. Our job is to treat this, the dysphoria. Okay, and then in other specified feeding and eating disorder, under that chapter, there's atypical anorexia nervosa. They did do a language change here because people were assuming that, okay, so here it is. New language states that people with atypical may also experience physiological complications, but still be atypical. This was important because there was some language in there that made it sound like if you're experiencing physiological complications, then you're no longer atypical, you're back to typical. They're leaving that open and saying, no, you can still be atypical even with that criteria. So it's just clarification. And then here, post-traumatic stress disorder. In criteria A2 in children 6 years old and younger, they clean that up so as to not restate that the traumatic event cannot have been merely witnessed on media. So it's just language that's not redundant. That isn't really changing the diagnostic structure. They just realized that some of the language was a little blurry, and so they just cleaned it up. So you already know that PTSD in children has to be an experienced event. It can't be witnessed. All right. Finishing up, should I buy the DSM-TR, DSM-5 TR? My ruling, probably not. I think you'll be fine. I'm buying it because I'm really gung-ho about just having stuff like this and making sure that I've read through it cover to cover and knowing it as cleanly as I can. But from what I'm gathering, if the way they're presenting it and the way that they're characterizing changes is true, then I think you could probably just get away with the desk reference. I think you need to know some coding, but you probably don't need to have it. Things that you need to make sure you're doing right. You need to make sure you're getting these diagnostic codes of suicidal behavior correct and non-suicidal self-injury. So just make sure that you're mentally shifting to that new mentality of understanding this is now being tracked. It's not merely collapsed inside of one of your other diagnoses. This needs to be independently diagnosed. It's an R code, T code, or Z code. So just make sure you're using that. And then allowing for those superimposed diagnoses that we talked about. You've been taught up to now and trained on DSM-5 to have exclusionary thinking, like it's either or, but now that's shifting. So psychotic and mood disorders can coexist. They can be superimposed. So just make room for that because you might be noticing that and you want to, diagnose that. And then just be sure to double check your specifiers and your severities. As I talked about, some specifiers don't exist anymore. Some severities and specifiers have been added, like in bipolars. And so just make sure you're seeing that because there's a lot of extra data that you can now reflect in your diagnosis. And you want to make sure that you're doing that and not just leaving it open. Anyway, friends, I'm Jim. Hope this was helpful to you. Again, it's designed mostly for clinicians. I hope that this is something you'll continue to research. Don't let me talk you out of buying the DSM-5 TR. I think as a default, you should just own it. But at the end of the day, I think from what I'm reading, you could probably get away with just having one in your office among your clinicians or just getting a desk reference that we are getting the coding right. So that would be my impression of it. Thanks for watching. And thank you for all that you do for mental health. And keep out there and keep doing the darn thing. Be well.